basic ankle scan of the anterior ankle. So one big home base could be right over the, just a transverse short axis view across the anterior part of the ankle. And right off the bat, we see a few different tendons, right? So right there in the middle of the screen right there, we got anterior tibialis right there, a short axis view. Okay, we got your EHL right there, okay? And what's cool about this, you can actually ask people to move their toe, and what I could do is I'm gonna lift up your toe a little bit, so I have a little bit of offset there. You can actually move the toe, and you got your EHL there. And then over here, you got your extensor digitorum, okay? And those are all short axis views. This off so you can relax a bit. Any of those tendons, you can look in long axis as well. So anterior tibialis, you can follow a short axis line distally all the way down to where it inserts right there as it fades into the bone right there, okay? And then also within any of these, I often recommend first finding them in short axis and then turning long axis to line up right on it. And you don't have cankles like a lot of my patients, so we got a little bit of kind of have the little crevices, and so if you run into a lot of trouble, you can put a big dollop of gel as a standoff. Right there, you can see her anterior tibialis in long axis right there, right across the top.
Talus navicular medial cuneiform.
And then, yep, and then you got your joint right there. So as far as access for injecting for ankle joint, one of our favorite approaches actually is to kind of hover over the anterior tibialis, going long axis here, and there you can see the talar dome, as well as the tibial plafond right there, and you got that fat pad deep to it. And so often you can guide a needle either out of plane this way or a short kind of combination of short and long axis, and put the needle down underneath that triangular fat pad. Everybody see that triangular fat pad there? And get into the joint and elevate that fat pad by injecting fluid there. So that is a quick demo of that, okay? Also likewise, if you look into the anterior tarsal tunnel, any of these tendons, you can go long on it. Here's your EHL in long axis, okay? It says your digitorum as well. But you could also look at the deep peroneal nerve, as well as the anterior tibial artery, which is becoming the dorsalis pedis artery, right in the middle. Do you see underneath those muscles and tendons? There's a round anechoic structure that's an artery right in the kind of in the middle of the screen right there. And flanking it are going to be the deep peroneal nerve, and you can kind of see it right there. Yep, right there, yep. And so it's variable because it often crosses it. There it is crossing over the artery. See that? There it is. You guys see that? I'm kind of making it go over, back and forth, the artery right there. So you can actually find that nerve there. So you can see how what you're looking for is that kind of hyperechoic cluster of grapes structure kind of crawling over the artery. Everybody see that right there? Okay, so that's going to be your deep peroneal nerve. You can continue following it, and there it is, kind of in the middle. It's really small, all right? And you can follow it all the way over here as we kind of start approaching it over the ligaments here, okay? Do you see it right there? There's a branch, the lateral branch is kind of coming over here, the extensor digitorum brevis right there. Yep.
AAPSM is right.
Yeah, you got it. That's right.
Where's
So-
the nerve right there?
So this branch, the lateral branch, is right underneath.
That little white.
Yeah. Can you point that out there?
Right there.
Yeah, right there. So if I go proximal, it's going to slide a little bit to the left. See that? If I go distal, it's going to slide a little bit to the right. Okay? That would be that branch there. And then there's another tiny branch that's in the middle of the screen in that corner of the EDB right there. Yeah, right there. And that's a really tiny branch that ends up. I'm going to keep it in the middle of the screen. Do you guys see it? Kind of moving back and forth on the top of the screen. We keep following that. Now it's going to be right on top of the Lis franc. See that right there? So right there. Yep. And so that's where I'm, like in my talk, you can get so like I had that patient who had Lis franc surgery, healed from that, but had some scarring after the hardware was removed that was entrapping that nerve. These are tiny nerves. They're hard to see, But I think the key is to go where you find the nerve, where you know where the nerve is, like here by the vessel, and just track it down, right? So that was some anterior structures. I think there was a question about looking at the Lis franc as well. So the dorsal oblique ligament, which I just showed, one other place to find it, just to kind of make things make sense, is start distally or between the first and second ray. If you look at the bony, the dorsal bony cortex of the first and second metatarsal there, as I slide north, short axis slide north, I'm gonna look for one of those bones to shift, okay? And so you can see as we get more proximal, and watch that first metatarsal, and there it is shifting to a different bone. You see that? See that? But notice how the bone on the right kind of remains. You see that? It doesn't really blink like the one on the left. So what you're looking at here is that the right remains the second metatarsal, while the left bony cortex is actually sliding off of the first metatarsal and onto the first cuneiform. And right there, you can actually see the dorsal obliquus frank ligament. And if you look closely enough, if you hit freeze right there on the
There's
machine,
a nerve right there, the deep cranial nerve right
yep, you can find the deep peroneal nerve sitting right on top, okay? So I don't want to mash it on too long because then you'll get paresthesias. But anyways,
Usually you do neurolysis.
that's right, huh?
Usually you're in the transverse like that to look at the Lis frank ligament.
Yeah, I mean, it's how you orient kind of depends on what you're looking at. But I think that, if I had to choose one orientation to start with, it's always going to be kind of this axial cross-sectional view, because it allows me to see multiple things and get a lay of the land. Because if I start this way, I'm going to be like, well, which tendon am I on? Am I on tib ant? Am I on EHL? Here I can actually see all three and figure out where I'm at, so I don't get lost. Was there anything in the dorsal anterior you guys, faculty, want me to demo other than that? Cool.
Maybe you can show them the first MTP joint, long
sure.
axis.
Yes. Bread and butter.
Yeah, bread and butter stuff.
All right, so this one's a good one too. So right on top right there, you can see the joint, and you can see the little triangular cleft in the middle with the bone on the left being